Ladies and gentlemen, thank you for watching this training webinar. Our webinar is about using clinical algorithms and measurement tools to improve the management of COVID-19 patients. Before introducing the faculty members, I would like to highlight that this webinar has been approved by the National Association for Healthcare Quality for a maximum of 2.5 CPHQ continuing education credits. Watching this recording is free. However, if you wanted to get a certificate of attendance, including the continuing education credits, you have to watch the whole recording and register yourself in the attendance sheet, which is available via clicking the registration link in the description box. After registration, you will receive an email with 2 post-activity assessment exercises, a link to a multiple choice quiz, and 4 other links to data collection forms. To answer the quiz, pay attention to the questions which are going to be displayed while you are watching the webinar. To respond to the second post-activity exercise, download the email attachment which represents the documentation forms, then enter the data into the corresponding field in the data collection forms. Once you score 80% or more in both exercises, you will receive the certificate of attendance showing your continuing education credits by the end of the same month. Our faculty today includes 5 members. I'm the moderator of the webinar. My name is Hussam Al-Amir. I'm a physician by background and hold a postgraduate diploma in quality and a master's degree in healthcare management from the Royal College of Surgeons in Ireland. I worked in the National Guard Health Affairs and the specialized medical centers before joining the Quality and Accreditation Directorate in Ministry of Health, Kuwait, where I was appointed as the head of Quality and Accreditation Department in one of the general hospitals for 7 years, then a leader of the technical support team to this day. I'm a certified professional in healthcare quality, a certified professional in healthcare risk management, a fellow of the International Society for Quality in Healthcare, and a Team Steps Master Trainer. The second speaker will be Dr. Ahmed Salim. He is an anesthesia and ICU specialist at Sabah Ahmed Urology Hospital, Ministry of Health, Kuwait, and assistant professor of anesthesia and intensive care of the Faculty of Medicine, Benha University, Egypt. Dr. Ahmed holds a doctorate degree in medicine, Faculty of Medicine, Benha University Hospitals, and diploma of the European Society of Anesthesia. In addition to his clinical role, Dr. Ahmed worked as a coordination of the specialized/critical care self-assessment team in the National Accreditation Program. He is a Team Steps Master Trainer and a leader of the COVID-19 team. He has special interest in healthcare quality and patient safety. Dr. Ahmed attended Teach the Teacher and Patient Safety and Quality Masterclass. The following speaker is Dr. Ibtisam Hamdi. Dr. Ibtisam holds a bachelor degree in medicine from Qasr Al Aini Medical School, Cairo University, a postgraduate diploma in clinical microbiology from Al Azhar University, and a postgraduate diploma in healthcare quality management from Cairo University, Egypt. Dr. Ibtisam joined the Quality and Accreditation Directorate, Ministry of Health, Kuwait in 2016 as a member of the technical support team to this day. She is a certified professional in healthcare quality, a fellow of the International Society for Quality in Healthcare, and a Team Steps Master Trainer. The fourth speaker is Dr. Muhammad Jalal. Dr. Muhammad holds a master's degree in hospital management logistics from the Arab Academy for Science and Technology, a postgraduate diploma in healthcare quality management from the 6th of October University, a bachelor degree in medicine from Benha University, Egypt. Dr. Muhammad is the head of quality and accreditation department in one of the Ministry of Health hospitals and the leader of the technical support team. The last speaker is Dr. Lamia Ali. Dr. Lamia holds a PhD degree in public health from the Faculty of Medicine, Fayoum University. She is the head of the quality and accreditation department in one of the general hospitals in Ministry of Health, Kuwait, and the lecturer of public health in Fayoum University. She is a member of the National COVID-19 team, Ministry of Health, Kuwait. Dr. Lamia also worked as a trainer in the Fayoum Leaders Developing Programs Center. So what are the learning outcomes of this webinar? By the end of this activity, we hope that participants will be able to identify the value of standardization and be able to use clinical algorithms as a decision support tool. Also, they will be able to explain what does a good communication look like and list different types of performance indicators, and finally, state the steps of developing performance indicators. So what do we have to present to you today? We will start by a definition. Whether for teaching clinical decision-making or guiding clinical diagnosis and management, a clinical algorithm is defined as a graphical set of sequentially detailed explicit steps and instructions which guide healthcare providers on how to perform a procedure appropriately. Based on the best available clinical knowledge and best practices, we are a multidisciplinary group of clinical and quality experts who undertook the development of a clinical algorithm-based toolkit to guide training and practice for the management of COVID-19 patients. So why do we need clinical algorithms? For the past 2 decades, research has shown that non-compliance with clinical practice guidelines is the third leading cause of preventable patient deaths and is responsible for 1/3 of wasted healthcare expenditure. In this context, clinical algorithms can help to obtain the full potential of the clinical guidelines. We have a large volume of published literature on the topic of COVID-19 pandemic, and we translated them into a user-friendly algorithm-based toolkit for the management of COVID-19 patients. The algorithms can be used for training and improving the quality of care provided to COVID-19 patients. They also act as decision support tool, and this part needs more elaboration in the next 2 slides. In his book, Critical Path, Richard Fuller, an American architect and futurist, created the knowledge doubling curve. He estimated that if we took all the knowledge that mankind had accumulated and transmitted by the year 1 current era as equal to 1 unit of information, it probably took about 1,500 years or until the 16th century for that amount of knowledge to double. The next doubling of knowledge from 2 to 4 knowledge units took only 250 years. By 1900, knowledge had doubled again to 8 units. And by the end of World War II, knowledge was doubling every 25 years. Some years later, a report published by IBM predicted by 2020, which means this year, knowledge would double every 12 hours, fueled by the Internet of Things. Different types of knowledge have different rates of growth, but it's generally acknowledged that human knowledge is increasing at an extraordinary rate. It is estimated that the doubling time of medical knowledge in 1950 was 50 years, in 1980, 7 years, and in 2010, 3.5 years. In 2020, it is projected to be 0.2 years, which means just 73 days. Arguably, we may have reached a point where relevant knowledge is increasing faster and in greater quantity than we can absorb. However, while knowledge is increasing, the useful lifespan of knowledge is decreasing. The information processing model explains how a human responds to an external stimulus. As you can see, we sense all the time external stimuli, but we attentionally perceive some of them according to the free attentional resources we allocate to them. And by perceiving them, we will be aware of them and we will use our working memory to interpret these stimuli to understand them, and then we select the proper response. If we don't have a long-term memory, as the current situation, COVID-19, we are going to rely on our working memory alone to memorize the huge volume of recent information. And because we are working in unusual situation, our attentional resources are limited and depleted. So the COVID-19 pandemic represents an unusual challenge to healthcare system and to nations across the world. Particularly challenging are the lack of agreed upon management guidelines and variations in practice. In our hospital, we increased our capacity by approximately 28% to manage the care of COVID-19 patients. The surge in capacity has necessitated the redeployment of staff who are not well trained to manage such conditions. There was great need to develop a tool to help redeployed staff in decision-making for COVID-19 patients, a tool which could be used for training also. As you can see in this graph, the unusual situation together with the unavailability of long-term memory impacted the clinician's situational awareness and put huge stress on the clinician's attentional resources. The algorithms are considered a highly effective means of handling clinicians' limited cognitive capacity when overwhelmed by a dramatic increase in new clinical information in a short time as they free the working memory space. And by this, I finish the introduction part and I will hand over the mic to Dr. Ahmed Salim to explain the COVID-19 clinical algorithms.
So before we start our algorithm, I would like to highlight some points related to the pathophysiology of COVID-19 and inflammatory stages. The first stage, the patient comes complaining from fever, dry cough, myalgia, nausea, vomiting, diarrhea. The duration of this stage is around 1 week. The second stage, it begins on day 7. The patient started to complain of shortness of breath and dyspnea. This stage is from day number 7 to day number 10. Finally, the third stage, with maximum response of the immune system, and the patient start to develop RDS. Pathophysiology, hypovolemia, coagulopathy, RDS are the 3 pillars of COVID-19 cases. Hypovolemia. The early cause of hypovolemia is dehydration, and the late cause is sepsis. All of this will lead to decrease of the blood flow and finally will lead to multiple organ dysfunction failure. The second pillar is the coagulopathy, will increase the risk of thrombosis and finally will lead to multiple organ dysfunction failure. The last and the third pillar is RDS. In RDS, there is endothelial cell damage that lead to capillary leak and lead to VQ mismatching. In addition to the thrombosis, all of this will finally lead to hypoxia and multiple organ dysfunction failure. Now let us go to the first algorithm.
The first algorithm, patient categorization or patient allocation. We depended on modified early warning score for categorization the patient in the ER. And according to the score, the patient destination is determined. Muse score includes respiratory rate, oxygen saturation, systolic blood pressure, heart rate, level of consciousness. If the score is between 1 to 4, the patient should be admitted to the ward with oxygen therapy in form of nasal cannula up to 6 liters per minute and regular monitoring of oxygen saturation respiratory rate every 6 hours at least.
If the score is between 5 to 6, the patient have to be admitted to the ward with oxygen mask up to 10 liters. Moreover, if the SpO2 is below the target, shift to the non-repressing mask from 10 to 15 liters. And here monitoring for SpO2, respiratory rate, heart rate, and the blood pressure should be every 2 hours. If the score is more than 6 points, patient have to be admitted to the intermediate care or high dependence unit. And according to the hospital protocol, high flow nasal cannula or CPAP can be used as a short trial. But if the patient work of breathing is high and respiratory rate is high, SpO2 is low, shifts the patient to ICU for intubation and mechanical ventilation. Threshold can be modified according to the system capacity and resource availability. And don't forget, only oxygen supplementation for desaturated patient. Coming to the second algorithm, oxygen escalation therapy. This algorithm is to be used in the ward and also in the intermediate care unit. First of all, the target from using oxygen is maintaining oxygen saturation between 92 to 96 and respiratory rate have to be less than 30 per minute. With taking in our consideration, COPD case oxygen saturation target should be between 88 to 92. Starting by the nasal cannula or oxygen mask 5 to 10 liters. If the SpO2 is still below the target, start to use a non-repressing mask from 10 to 15 liters by gradually increase. If the patient saturation is still low and respiratory rate is more than 30 and there is increase in the work of breathing, shift the patient to the intermediate care unit and start high flow nasal cannula. Our protocol is to start using a high flow nasal cannula with FiO2 100%. With flow 60 liters, every 10 liters of the flow giving a pressure 0.7 with closed mouth and 0.3 with open mouth. So the patient cooperative is very important in this type of oxygen therapy. After 1 hour, respiratory rate, oxygen saturation, and work of breathing should be checked. If respiratory rate is less than 30 and oxygen saturation between 92 to 96, and there is an improvement in the work of breathing, so start to decrease the FiO2 as tolerated by the patient, and SpO2 is still within range. Then gradually decrease the flow 5 liters per minute every hour until FiO2 become 40% and the flow 20 liters per minute. So now we can stop high flow nasal cannula and return to oxygen mask 5 to 10 liters per minute. At any stage, if the target is not achieved, return to the previous setting in high flow nasal cannula. When you are using high flow nasal cannula with maximum support, FiO2 is 100 and the flow 60 liters, in both prone and supine position, there is an increase in the work of breathing. Respiratory rate is more than 30 and SpO2 is less than 90. So now it is the time for the short CPAP trial only for 1 or 2 hours. by starting with 13 to 15 centimeter water and FI 200%. If there is any improvement, continue using CPAP. If there is no improvement and there is a sign of non-invasive ventilation failure, like increase in the work of breathing, increase in the respiratory rate, tidal volume is more than 10 milli per kg, and EPG is not improvement, so shift your patient directly to the ICU. Self-proning position is being advisable in all stages. Don't forget to use ROX index for early expectation of high flow nasal cannula treatment failure. Coming to the third algorithm, the most common question nowadays is early or late intubation. Professor Gattonini and his colleague adopt the theory of patient self-induced lung injury. Self-induced lung injury is starting by initial lung injury and capillary leak. Edema will start to happen and impaired in gas exchange. This will lead to increase in the respiratory drive in form of increase in the tidal volume and the respiratory rate. This lead to decrease the pressure in the alveoli, increase the tidal volume, increase the pendular effect between the alveoli. This lead to self-induced lung injury, and it will lead to capillary leak and continue of the vicious circle. And Dr. Gattonini and his colleague advise the early intubation. On the other hand, Dr. Toppin and his colleague are totally against the early intubation, even against the theory of patient self-induced lung injury. On the pretext, it's a new theory. Just 4 to 5 years come to the surface. In addition, they didn't give a clear advice when to intubate the patient. Actually, in our practice, we are used to escalate oxygen therapy by using high flow nasal cannula. We start by high parameters, FiO 200 and flow 60. So it's easy to pick up the patients that will not benefit from high flow nasal cannula early. In addition to using ROX index would help in early expectation of high flow nasal cannula treatment failure. So again, if the patient is not responding to the escalation oxygen therapy, and there is increase in the work of breathing, and SpO2 is less than 90 and respiratory rate is more than 30, and there is an impaired in the conscious level, so no way. Intubate the patient and start the mechanical ventilation. This is a diagram that we have follow for intubation. Intubator standing here at the head of the patient with 2 assistants, one for drug injection and looking for the monitors, and the other for helping during the intubation, in addition to the runner, which will be outside of the room. I would like to emphasize the steps during intubation. Take one step back and stretch your arm. Face mask with a good seal with viral filter. Video laryngoscope, it's better for your safety. Little patient head up and keep the high flow on, but don't forget to turn it off just before you started using your laryngoscope. Better for 5 minutes pre-oxygenation to increase the oxygen for the patient, decrease your heart rate, your blood pressure, your stress, and lower your cognitive load. Before getting out of the room, don't forget to insert the intravenous line, NGT, and urinary catheter after the intubation to decrease the exposure of the staff.
Now, after intubation, this is a time for adjustment the ventilator setting, the fourth algorithm, starting by the mode of mechanical ventilation, assistant volume control or assistant pressure control. Some intensivists prefer volume and others prefer pressure. My advice is using the mode you are familiar with. First of all, initial ventilator setting. Start by tidal volume 8 ml per kg according to the predicted body weight, and PEEP 8 cm water and FiO2 100%.
Respiratory rate and FiO2 should be adjusted to achieve the target. Target is SpO2 between 92 and 96%. PO2 more than 8 kilopascal. And plateau pressure less than 30 centimeter water and driving pressure less than 15 centimeter water. So after initial setting of adjustment, we have to check the driving pressure. Now, there is two questions. What is the driving pressure? What is the importance of it? What is the driving pressure? Driving pressure equal to plateau pressure minus PEEP. For example, if the plateau pressure is 28 and PEEP is 14 centimeter water, so the driving pressure will be 14. Answer of the second question is, what is the importance of the driving pressure? Driving pressure is the only variable that closely related to the mortality. High driving pressure means high mortality rate. So if the driving pressure is less than 15 centimeter water, so tidal volume equal to 8 ml per kg is acceptable. However, if the driving pressure is more than 15 centimeter water, so tidal volume should be between 4 to 6 to achieve the driving pressure around 15 centimeter water. Next step, if PO2 is less than 8 kilopascal, by using FiO2 more than 70% and the driving pressure is less than 15 centimeter water, so you have to increase the beep through beep adjustment titration methods. By increase the beep from 8 to 10 and wait 10 minutes, and after that you have to check if there is any improvement in the oxygen saturation or PO2, and also there is an improvement in the compliance or not. If there is no improvement and the compliance is not affected, so you can increase the PEEP to 12 centimeter water, and you have to wait another 10 minutes, and after that you have to check if there is improvement in the saturation or PO2. If there is no improvement, you have to increase the PEEP to 14 centimeter water. At any step, if there is no improvement or decrease in the compliance, please try to return to the previous PEEP. If PO2 is still less than 8 kilopascal, FiO2 more than 70%, and PEEP is adjusted already, so check the compliance, and according to the compliance, there is an L type or H type. For L type, it's better to start by proning position. For H type, it's better to follow the FiO2 PEEP table and do a recruitment. Recruitment maneuver, there is two considerations. Blood pressure, you have to keep your eyes on the blood pressure because some patient may develop hypotension during this maneuver. Secondly, your patient should be completely paralyzed or deeply sedated. How to do this maneuver? Increase your FiO2 to 100% and decrease tidal volume to 150 ml and increase PEEP to 40 centimeter water for 20 seconds. And please don't forget after the maneuver to come back tidal volume and the FiO2 to their initial value and return to PEEP to the previous value, and sometimes you need a higher value from PEEP. Next step, after of all this maneuver, if still PO2 is than 8 kilopascal and the FiO2 more than 70%, usually this patient suffer from hypoxia and hypercapnia. So try to use high frequency oscillatory ventilation or airway pressure release mode if you have experience with it, or go directly to ECMO if you have this facility. You might face a challenging scenario like increase in the driving pressure more than 18 centimeter water, plus PO2 FiO2 ratio less than 150, and carbon dioxide tension is more than 6.4 kilopascal. So 60% of this problem may be right ventricular failure. So you have to do an echo to check there is any right ventricular strain or not, and you should decrease the PEEP, increase respiratory rate, and decrease the tidal volume to 4 ml per kg to decrease the driving pressure. And my advice in this situation is early proning position. Now this is the most important and the most condensed algorithm. The fifth algorithm is about how to deal with the hemodynamically unstable patient in a COVID ICU. First of all, I would like to start by the hemodynamic sequence on a ventilated COVID case. By initiation of the mechanical ventilation, there is a decrease in the right ventricular preload, which is due to compression on the severe vena cava bipleural pressure. In addition to increase in the right ventricular afterload, which is due to compression in the pulmonary capillary, in addition to the RDS itself. So all of this result in decrease in the cardiac output. And we don't forget there is another kind of shock will be present, like a septic shock, cardiogenic shock, hypovolemic shock due to prolonged fever and vomiting and diarrhea. All of this will lead to circulatory shock and renal failure. AKI, it's around from 27 to 85% of the cases. Finally, will lead to multiple organ dysfunction, failure, and death. So our target is how to interrupt this sequence by follow this flow chart. Before we start the flow chart, I would like to emphasize about our target. Our target is to keep the mean arterial blood pressure more than 65, with a special consideration to the hypertensive patient, in addition to keep adequate tissue perfusion. You might face all type of shock in the COVID ICU. Let us to start by the most common type shock in COVID ICU is disruptive shock. Disruptive shock, vasoplegia, vasodilatation of the blood vessels. The cause of the disruptive shock may be due to high dose of the sedation or septic shock. Sedation effect, so my advice is to avoid the vasoplegia is by follow the RASO score assessment and should be -4 that allow ventilator patient synchronicity and prevent the over-sedation. The second common cause of disruptive shock is a septic shock. And we will come later to discuss the septic shock. The second common cause of hemodynamically unstable patients in a COVID ICU is a hypovolemic shock. The hypovolemic shock most probably due to dehydration or sepsis. Dehydration is due to fever or fluid loss due to vomiting and diarrhea, or due to sepsis due to vasoplegia, as we discussed before, or from absolute capillary leak. So in this situation, the management, as we know, is a vasopressor and fluid. But the problem is any extra fluid you give, the more fluid will escape from the capillary, more capillary leak, more pulmonary edema, as discussed in the pathophysiology at the beginning of our presentation. So you should be very cautious. So how we can deal with this? Risk-benefit fluid should be considered. So you have to assess the fluid responsiveness regularly. So now the question is how to assess the fluid responsiveness in a COVID case in ICU. There is many methods to assess the fluid responsiveness in ICU case, starting from the real-time heart-lung interaction. It depends on the effect of the respiration on the stroke volume. It includes pulse pressure variation, stroke volume variation. But the problem, we are using low tidal volume in most of the case, in addition to bad lung compliance. And in some patients, there is a right ventricular failure. Also, we cannot use this on the prone position. So all of these are a limitation for this kind of methods. The second one is ultrasound for checking the IVC diameter during and inspiration. It's a non-invasive test, not costly, but the only disadvantage is not applicable in the prone position and we are using a prone position in RDS cases. The third one is a preload challenge methods. Preload challenge method, we can use it in an umbralized patient, and even we can use in a low lung compliance and in right ventricular failure. There is many methods we can use in the preload challenge test, like a passive leg rising test, mini flow challenge test, and expiratory occlusion test, tidal volume challenging test. But I would like to emphasize that in many flow challenge tests and in expiratory occlusion test, it needs a real-time cardiac output monitoring. In the tidal volume challenge test, it's a high sensitivity test, and also we can check the different pulse pressure variation difference. But the disadvantage of all of these methods is inaccurate on the prone position. The only one that we can use during the prone position and during supine position is the passive leg rising test. We can use it during the supine position and the prone position. So we face a big problem now, how to assess the fluid during the prone position. Okay, but let us to start from the supine position. How to assess the fluid during supine position? By the passive leg rising test. Passive leg rising test is a simple test, non-invasive test, no need for any device like a cardiac output or ultrasound. Patient already in the sitting position 45 degree. We have to check the pulse pressure. After that, lower the head to the neutral position and elevate the lower limb to the 45 degree and wait 1 minute and check the pulse pressure. The pulse pressure is the difference between systole and diastole, and you have to compare between the pulse pressure between the two positions. If the pulse pressure difference more than 10%, this means that the test is positive and the patient needs a fluid. Now, our challenge with the prone position. There's an easy maneuver also we can follow. It's a non-invasive maneuvers, Trendelenburg maneuvers. Patient is already in prone position with head up 13 degrees. So you check and record the pulse pressure. And change the position of the patient with head down 13 degrees. And wait 1 minute and just check the pulse pressure. And compare between two of them. If the pulse pressure difference is more than 10%, this means that the patient is already need a fluid. So the result will be fluid responsiveness test, positive or negative. If the fluid responsiveness test is positive, this means that the patient is hypovolemic. So give 250 ml fluids and after 10 minutes reassess again. And please don't forget to check the tissue perfusion after fluid replacement by checking lactate, capillary refill time, delta PCO2, urine output, echo. Delta PCO2 is the difference between PCO2 from the central venous line and from the arterial line. For me, I prefer to follow the capillary refill. It's a non-invasive test by compression of the nail bed for 5 seconds. And after that, you relieve your compression and you have to check the capillary refill time. If the capillary refill is less than 3 seconds, this means that the patient is already with good tissue perfusion. And you have to start weaning the vasopressor. Also, you can use the delta PCO2. Delta PCO2, if it's less than 6 millimercury, this means that this patient with adequate tissue perfusion. And also you can use lactate, but I didn't prefer lactate because there is a delayed response. If there is no adequate tissue perfusion in the form of delta PCO2 is more than 6 millimercury and the capillary refill is more than 3 seconds, so you have to start adobutamine, 5 mic per kg per minute at least, even if there is a normal blood pressure. On the other hand, if the fluid responsiveness test is negative, this does not mean that your patient is okay. Absolutely. You have to be very cautious and do at least basic critical care echo. And according to it, you will start your management. Maybe there is a normal echo, so there is no intervention. Maybe there is a small ventricle, so your patient need IV fluid. And after you give a fluid, don't forget to check the tissue perfusion. Secondly, maybe there is a large ventricle and a poor contraction, the cardiogenic shock. And finally, maybe there is a right ventricular dilatation and the D-shape in the echo. So there is an obstructive shock or VE. Coming to the third cause of shock in a COVID cases, cardiogenic shock. Cardiogenic shock, maybe it is the first presentation of COVID cases or complicated problem during the ICU stay. Maybe due to acute coronary syndrome, arrhythmia, myocarditis, heart failure. So firstly, you have to do an ECG and send the cardiac enzymes, and you have to assess the right and left ventricular function by echo. The last type of shock is the obstructive shock, or to be generalized, right ventricular failure. Maybe due to RDS, which lead to increase in the pulmonary pressure, mechanical ventilation, as we discussed before, increase the pulmonary pressure, or massive PE. In this kind of shock, the CVP will be high, and you have to assess the left ventricular and right ventricular function by doing echo. In massive PE, CT angio should be done and start as thrombolysis. We will discuss this later in other algorithms. If the cause of failures due to RDS or mechanical ventilation, you have to decrease your driving pressure plus 15 and decrease PEEP and starting proning position. And we discussed this in the previous algorithm. Let us to go to the sixth algorithm. When to use immune suppression in a COVID case. First, you have to assess the risk of development of cytokines storm or cytokines releasing syndrome by modified H-score. Modified H-score, which include temperature, number of cytopenia, triglyceride, fibrinogen level, ferritin, AST, and you have to know this patient is already immune suppressed or not. And according to the score, if the score is less than 132, this means that there is no storm. It is only COVID pneumonia. So dexamethasone 6 milligram OD, it's enough. On the other hand, if the score is more than 132, this means that the patient is already in cytokines releasing syndrome or cytokines storm. So in addition to corticosteroid 6 milligram dexamethasone milligram OD, we will add a tocilizumab. Tocilizumab dose, it should be 4 to 8 milligram per kg diluted in 100 ml normal saline IV infusion over 1 hour. And we have to repeat CRB after 24 hours. If the CRB is still increasing, so we have to give a second dose. But before giving tocilizumab, we should put in our consideration contraindication of tocilizumab. So the patient should be free from TB, hepatitis B, HIV. There is no fungal infection. There is no bacterial infection. Patient is already not in neutropenia. And also, I would like to emphasize the side effect of tocilizumab. Some patients developed increase in the liver enzyme, some patients develop neutropenia, and others develop thrombocytopenia. The next algorithm, how to prevent microthrombi in a COVID-19 patient. Preventing microthrombi through anticoagulant therapy, antiplatelet, antithrombotic therapy. We will start by anticoagulant therapy. It might be prophylactic or therapeutic, according to the investigation. By starting by the prophylactic, if the ferritin is less than 1,000 and D-dimer less than 1,000 and fibrinogen less than 6.5, so a prophylactic dose of low molecular weight follow up by antitin A is appropriate management. On other hand, the indication of the therapeutic anticoagulant include severely critical ill patient when the ferritin is more than 1000 and D-dimer more than 1000 and fibrinogen more than 6.5. And if the nurse give you a feedback about the clotting in the IV catheter or extracorporeal circuits like dialysis circuits or ECMO circuits, the third indication, if there is a confirmed VTE but not massive, because if massive, it needs a thrombolytic therapy. The fourth indication for therapeutic anticoagulant therapy in a COVID case when suspected there is a VTE, like a patient was on prophylactic dose with sudden deterioration of the respiratory status and sudden decrease in the PO2, or sudden increase in the D-dimer, or by echo there is a right ventricular strain. And again, the dose of the heparin, low molecular weight or unfractionated heparin, should be adjusted by anti-10A within 48 hours of admission. After anticoagulant therapy, the second one is antiplatelet, aspirin 81 milligram OD. Coming to the antithrombotic therapy, the indication for antithrombotic therapy when there is a confirmed massive PE by CT pulmonary angio, in a hemodynamically unstable patient, or even in hemodynamically stable patient with right ventricular failure, or confirmed acute myocardial infarction by ST segment elevation, or confirmed acute ischemic stroke by CT brain. The last algorithm is the weaning of mechanical ventilation. Before going through the algorithm, we have to know that what is the weaning criteria. Weaning criteria including the respiratory, PO2 more than 8 kilopascal or PO2 FiO2 ratio more than 150 to 200. On FiO2 less than 40 to 50% with PEEP from 5 to 8. PaCO2 normal or baseline, except if there is a permissive hypercapnia used. Patient is able to initiate an respiratory effort. Cardiovascular weaning criteria should be there is no evidence of myocardial ischemia, heart rate is less than 140, and the blood pressure is normal without vasopressor or with minimum support. Patient should be arousable and afebrile, no significant electrolyte abnormalities, especially magnesium and phosphorus, and there is an improvement in the inflammatory markers. When the patient is fulfilling the weaning criteria, you have to know how long your patient on mechanical ventilation. If less than 1 week, so you have to start a spontaneous breathing trial for 2 hours with pressure support from 5 to 7. But if more than 7 days, you have to continue a spontaneous breathing trial for 24 hours. During this spontaneous trial, you have to check if the patient is low comfortable, rapid shallow breathing index is less than 100, rapid shallow breathing index is respiratory rate divided by tidal volume in liter. Respiratory rate should be less than 35, heart rate is less than 140, or not more than 20% of the baseline, oxygen saturation more than 90. If your patient is already fulfillment of all this criteria, so you have to check there is a cuff leak test to avoid laryngeal edema, and you have to ask the nurse and you have to notice that your patient has ability to cough. If cuff leak test is negative and a patient has the ability to cough, so you can extubate your patient. But if you suspected there is an laryngeal edema or there is a weak cough, so don't extubate the patient and consider tracheostomy. On the other hand, if you have noticed that your patient is not comfortable, or rapid shallow breathing index is more than 100, or the patient is tachypnea, or there is an increase in the heart rate during the spontaneous breathing trial, So you have to search about the cause. If there is an increase in the respiratory rate, check the tidal volume. If there is increase in the respiratory rate and increase in the tidal volume and the decrease in the PaCO2, this means that your patient is afraid from the weaning process and afraid from the extubation. So you can extubate your patient with minimal sedation, especially with dexamethasone. But if there is an increase in the respiratory rate and increase in the tidal volume and PaCO2 also increase, so your patient is not ready for extubation, so resume the ventilatory support again. On the other hand, if there is an increase in the respiratory rate and the tidal volume is decreased, this means that your patient is not ready and you have to resume the ventilatory support. When there is a weaning failure, you have to search about the cause of the weaning failure. For example, low cardiac output, patient suffering from myocardial ischemia, lung congestion, sepsis, metabolic disorders, electrolyte imbalance, weak diaphragmatic contractions, and finally, myopathy or polyneuropathy. Thank you.
Thank you, Dr. Ahmed, for this comprehensive demonstration. Some may claim that algorithms will create unable to think robotic clinicians with less individual autonomy and that they are inapplicable to specific patients. I'm quoting here the British mathematician and professor of statistics, George Box, when he said, "All models are wrong. The practical question is how wrong do they have to be to not be useful? Every patient is unique, and it's impossible to reflect the full complexity of reality and account for every single clinical eventuality. In fact, algorithms are frameworks used to facilitate thinking about clinical encounters in a branching logic, which allows individualization of management and care once the patient is thoroughly examined." And now we will go through a journey to explore how these algorithms could be implemented and monitored. Dr. Ibtisam will start by explaining two documentation forms.
The first form is the COVID-19 patient ward vital signs form. Our objectives are to understand the importance of document vital signs of COVID-19 patient in the ward, to know who can use the form, and to know the frequency and the correct way to fill the form. Moving through slides, importance of vital signs documentation to COVID-19 patient in the ward. Vital signs are an important component of patient care. Accurate documented vital signs of COVID-19 patient determine which treatment protocols to follow, provide critical information needed to make life-saving decisions, transfer the patient to a higher level of care, and they confirm feedback on treatments performed. Who can use the form? We assign the responsibility of fulfilling this form to the nurse staff providing care to the patient. Now let us go through the form section. The form composed of 3 sections. In the first section of the form, the nurse will document the patient name, file number, ward number, bed number, date of admission, numbers of days since admission, and Mayo score on arrival. The second section of the form contains a table of the vital signs. In the top of the table, the nurse will document the date and patient needs one form for each day. The items in this form supposed to be documented according to the patient Mayo score. patient scored 1 to 4 need follow-up and documentation of oxygen saturation, respiratory rate 4 times per day, every 6 hours. While patients with Mayo score 5 to 6 need follow-up and documentation of oxygen saturation, respiratory rate, heart rate, and blood pressure every 2 hours, 12 times per day. So the nurse will document the time when checking the patient every time. This section regarding vital signs of the patient, temperature, respiratory rate, oxygen saturation, systolic blood pressure, heart rate, level of consciousness, and Mayo scores. Changing in vital sign and oxygen saturation will change the Mayo score and the management of the patient accordingly. In oxygen escalation therapy, the target is SpO2 from 92 to 96% for regular patients and from 88 to 92% for COPD patients, and respiratory rate less than 30 per minute. In this part of the form, the nurse will document oxygen supplement, ROX index for the patient on high flow nasal cannula, so we can know the patient with low risk for intubation and predict the failure of high flow nasal cannula. Self-browning compliance. The patient is supposed to change his position every 30 minutes to 2 hours, starting full proning position, then right side, semi-sitting, then left side. So, current position of the patient should be checked at time of documentation. And if the patient is comfortable without increase in work breathing or not. Accordingly, the management will change either to decrease the oxygen flow or transfer the patient to ICU. Finally, the nurse will sign each time. The next form is for mechanical ventilation and hemodynamic management for COVID-19 patient in ICU. Our objectives are to understand the importance of documenting mechanical ventilation and hemodynamic data for COVID-19 patient in ICU, to know who can use the form, to know the frequency and the correct way to fill the form. We will moving through slides. For patient on mechanical ventilation in intensive care unit, numerous ventilator settings are adjusted to provide appropriate oxygenation and ventilation and to facilitate weaning. Nurses periodically observe setting on the ventilator that control oxygen flow, volume, and pressure. For ICU staff, access to timely and accurate ventilator setting is essential for making treatment decisions and for maintaining situational awareness. We assign responsibility of fulfilling this form to the nurse staff providing care to the patient. Let us go through the form sections. The form was designed to cover two parts of mechanical ventilation part and hemodynamic management part. And in the lower part of the form, there are three tables. Lower beep, high FiO2, higher beep, lower FiO2, and the RAS score for the nurses to refer to it. In the first section of the form, the nurse will document the patient name, file number, ward number, bed number, date of admission, numbers of days since admission, number of days since ventilation. It is important to know the numbers of days since admission and number of days since ventilation because the management will change accordingly. Also, we will document weight, height, which are important to calculate predicted body weight. Last item is fluid balance of previous day, and it is important to know the hemodynamic status of the patient, and both items will change the management for each patient according to hemodynamic management of COVID-19 patient algorithm. Now for the mechanical ventilation section, according to the mechanical ventilation algorithm, the target is to make the SpO2 from 92 to 96%, BaO2 more than 8 kilopascal, BaCO2 less than 6 kilopascal, P-plateau less than 30 centimeter water, driving pressure less than 15 centimeter water. Now, in the form, the nurse will document following data: driving pressure, oxygen saturation, BaO2, FiO2, P-plateau, lung compliance result, patient proning in indicated patient, recruitment, then notifying the doctor. Doctor should be notified in each shift and document any new order according to the patient's status. The nurse signed for each. For the hemodynamic management section in the form, and according to the hemodynamic management of COVID-19 patient algorithm, the target is to make the mean arterial pressure more than 65 millimeter mercury and have adequate tissue perfusion. So the nurse will document the following data: RAS score, mean arterial pressure target achieved if yes or no, fluid responsiveness test done yes or no, or contraindicated, the result of the test if positive or negative, and it is important to document the result of the fluid responsiveness test because the decision of the management will be different. If positive, the patient is hypovolemic and need IV fluid. Then, regarding vasopressor dopamine dose, it is important to document the dose because it will be changed according to the case. The doctor can change the dose or stop the vasopressor. Then, capillary refilling test result less than 3 seconds or more than 3 seconds, 3 times per day, 1 time in each shift. Doctor should be notified in each shift and document any new orders according to the patient's status, and the nurse sign for each shift. Thank you.
Thank you, Dr. Tissam, for this detailed presentation. The two forms are to be used for documenting specific findings or critical readings for COVID-19 patients in wards and ICUs. We noticed that these readings were usually not documented in any place, which eventually leads to incomplete information sharing with different care providers. This simple intervention will help creating a shared mental model between the reporter and decision maker. And now, Dr. Muhammad will present 2 other forms which are designed to reduce the over/improper utilization of diagnostic investigations and medications.
I'm going to present 2 forms. The first one is the complete investigation order set, which lists the all related investigation the doctor may request for COVID-19 patients. We created this form because we noticed that some vital investigations are never requested while others are. The first form is an investigation order set for COVID-19 patient. It's divided in 2 main parts. In the top 4, we will find patient information, name, hospital location, and file number. The rest of the form is made of 6-column table which display the investigation that could be requested each day. Starting by day 0, the admission day, the doctor is required to mark next each investigation he or she thinks is essential for diagnosing or evaluating the patient. Following day 1, the doctor is required to select necessary investigation for follow-up. The doctor may prefer to take all investigation on admission or decide which investigations are needed day by day. Starting from day 5 and day 6, the listed investigations are be repeated every other day. And this part is guided for anticoagulation therapy follow-up. If the treating doctor wanted to order any other investigation, he or she can write it down in the free space. The second form is tocilizumab prescription order set, Actemra. We created this form because we noticed that the tocilizumab often described for non-indicated patient. Moreover, when it's indicated, the patient was not checked for contraindication to this medication. Similar to the first form, the top part is concerning of patient information. The rest of the form is divided into 2 parts. One to state the prescribed dose and other to make sure the patient is eligible for tocilizumab treatment. The doctor should check the contraindication and calculate if patient modified H score. The total score will be documented in the end of the form. As we can see, in addition to using the form to correctly to prescribe tocilizumab, it's considered a source of data to calculate the process indicator for COVID-19 patient. And that's it. Thank you.
Thank you, Dr. Muhammad, for this focused presentation. According to the Nabedian's SPO triad, indicators can be classified to structure indicators, process indicators, or outcome indicators. Structure indicators are indicators which measure the appropriateness and availability of optimum resources needed to provide high-quality care. Process indicators are those which measure compliance with a required policy or a guideline, while outcome indicators are those which measure the results of the management process. Dr. Lamia is going to discuss a set of 30 different indicators which can be measured for COVID-19 patients based on our clinical algorithms. But before that, Dr. Lamia will present the last documentation form, which is supposed to be used to document the intubation and weaning processes.
One of the implementation tools included in our training program is the intubation and weaning form. If a patient is becoming increasingly indicated despite individualized treatment based on their condition, the physician may decide that the patient requires advanced airway support such as mechanical ventilation. This form will help to memorize the needed steps prior and after intubation and documenting them, and as well as weaning process. The form is divided into 3 main sections: patient data, intubation items, and weaning. The first section includes patient data as name, file number, ward, bed, and admission date. The second section of our form includes intubation items. And as you can see, the intubation items are further grouped into a number of boxes. The first box is displaying the indication of intubation, where date, time, and related clinical indication parameters would be specified. And if there is any other indication not listed, it is preferred to be written. The subsequent box is displaying the intubation process needed equipment and requirements, which are degree of difficulty, which is ranging from 1 to 4, choice of the EET, size and length, and it is also preferred to state any other equipment used. Then the next box is considered as checklist of the medications which could be used during and after the intubation. After intubation, there are certain parameters should be checked and documented in the correlated box. These parameters are blood pressure, heart rate, and level of oxygen in the blood. The team names shared in the intubation process, and if the intubation process went smoothly, will be documented in the last two boxes in the bottom of the form. Passing to the third section of our intubation and weaning form, which explain weaning items needed to be followed and documented. The first box is displaying the weaning criteria, and all weaning criteria should be fulfilled. The healthcare provider will check what applies to patient condition and tick in front of it. Where the adjacent box is specified for documenting date, time, days on mechanical ventilation, and parameters on the CPAP, as rapid shallow breathing and respiratory rate, average tidal volume, oxygen, O2 and PaCO2, heart rate, cough leak test, the ability to cough, and number of hours on the CPAP. The subsequent box on the left is displaying the possible results of weaning trial. Either it was successful or not. Here are the options where the healthcare provider can choose from, which are successful extubation without minimal sedation, tracheostomy, extubation under minimal sedation, failure of weaning. Then we can check the parameters after the extubation, which are blood pressure, heart rate, and level of oxygen in the blood. The final box on the right hand is specified for displaying the ABG result after extubation, which are the pH, level of oxygen and CO2 and bicarb in the blood. And the final box on the left side is concerning about documenting the causes of weaning failure, like low cardiac output, myocardial ischemia, lung congestion, sepsis, metabolic disorders, or electrolyte imbalance. By reaching this slide, now we will start to explain the performance measures or indicators included in our training program, which were chosen very carefully to cover key points in each level of care included in the management journey and related algorithm. In all admission levels, there is a need to collect, analyze, and interpret data about timely anticoagulation prophylaxis, effective anticoagulation therapy, timely dexamethasone therapy, and appropriate tocilizumab indication. As you can see here, the time of the indicators, they are process except for the effective anticoagulation therapy. And in all of them, they are percentage. We have to estimate the percentage by the number of patients. As regard timely anticoagulation prophylaxis, number of patients received anticoagulation prophylaxis within the 24 hours of admission will be the denominator, while the denominator will be all discharged COVID patients. And as regard the effective anticoagulation therapy, we are concerning about the outcome, number of patients whom their anticoagulation achieved the target within 48 hours of starting anticoagulation therapy. As regard the timely dexamethasone therapy, we have to count the number of patients receiving dexamethasone therapy within 24 hours of admission from all discharged COVID patients. And as regard appropriate tocilizumab indication, number of patients received tocilizumab whom their modified H-score was more than 132 and has no contraindication, And the denominator here will be all discharged COVID patients receiving the tocilizumab therapy. Again, these 4 indicators, they are required in all admission levels. Now, we will discuss the indicators or performance measure related to the ward or intermediate care units. In this slide, they are displaying 5 indicators. The first one is appropriate patient allocation to the ward according to news score. Here the numerator will be number of patients scored 1 to 6 whom admitted to the ward, and the denominator will be all newly admitted to ward COVID patients, and it is a process indicator. The second one is appropriate patient allocation to the high dependence unit or intermediate care unit according to news score. The numerator here is the number of patients scored more than 6 whom admitted to the HDU or intermediate care, where the denominator will be all the newly admitted to the HDU or intermediate care unit COVID patients. Self-pruning position compliance, its numerator is the number of observations where patients were compliant with self-pruning position, and the denominator is all observation opportunities of discharged COVID patients. The first 3 indicators, they are process type. They are assessing the management process. The fourth one is still self-pruning position compliance reflected on oxygen saturation, where the numerator is the number of observations where patients were compliant with self-pruning position, whom their level of oxygen ranging from 92 to 96. And in COPD patients, it's ranging from 88 to 92. The denominator here, all observations of patients compliant with self-pruning position, and it is an outcome indicator assessing the outcome of the management process. The last indicator in this slide is the good oxygenation in oxygen nasal cannula. Number of the observation where patients were receiving oxygen via nasal cannula, whom their level of oxygen ranging from 92 to 96, and in COPD ranging from 88 to 92 in the COPD, and have no increase in work of breathing, and it is the numerator, while the denominator is all observations of patients receiving oxygen via nasal cannula, and it is also an outcome indicator. We will continue the performance measure. Here there are 7 indicators, and the first one is good oxygenation on oxygen mask, where the numerator is the number of observations where patients were receiving oxygen via oxygen mask, whom their level of oxygen ranging from 92 to 96, and in COPD 88 to 92, and have no increase in work of breathing. And the denominator is all observations of patients receiving oxygen via oxygen mask. The second indicator is good oxygenation on non-rebreathing mask. The numerator is the number of observations where patients were receiving oxygen via non-rebreathing mask, whom their level of oxygen ranging from 92 to 96, and in COPD ranging from 88 to 92, and have no increase in work of breathing. And the denominator is all observations of patients receiving oxygen via non-rebreathing mask. The third one is also as regard good oxygenation, but on high flow nasal cannula. The numerator is number of observations where patients were receiving oxygen via high flow nasal cannula, whom their level of oxygen ranging from 92 to 96, and in COPD ranging from 88 to 92, and have no increase in work of breathing. And the denominator is all observations of patients receiving oxygen via high flow nasal cannula. Again, as regards good oxygenation on CPAP, the numerator is number of observations where patients were receiving oxygen via CPAP, whom their level of oxygen is ranging from 92 to 96, and in COPD ranging from 88 to 92, and have no increase in work of breathing. The denominator is all observations of patients receiving oxygen via CPAP. As regards the transfer to the ICU, we have to count the number of patients transferred from wards or intermediate care units to the ICU, and the denominator is all discharged from ward, intermediate care unit COVID patients. Ward mortality rate of COVID patients, we have to count the number of mortality COVID patients in ward, which is the numerator, while the denominator is all discharged from ward or intermediate care unit COVID patients. The last indicator is average stay in wards or intermediate care units. The numerator is number of all days of wards or intermediate care unit stay, and the denominator is all discharged from ward or intermediate care unit COVID patients. And as you can see, all these 7 indicators are outcome. They are assessing the product of the management of our journey and implemented COVID algorithm. By reaching this slide, we will discuss the indicators as regards the hemodynamic management. In this slide, there are 4 performance measures. The first one is fluid responsiveness test compliance. The numerator is number of observations of performing fluid responsiveness tests, and the denominator is the number of opportunities to perform fluid responsiveness test of discharged COVID patients, and it is a process measure.
The second indicator in this slide is fluid responsiveness test guided hemodynamic management. The numerator is number of days where fluid responsiveness test was done at least twice, and the patient have fluid balance ranging from 0 to minus 500 milli per day, and mean arterial pressure more than 65 millimeter mercury with adequate tissue perfusion. The denominator is all ICU days of discharged COVID patients where fluid responsiveness test was done at least twice. The third indicator on this slide is the successful hemodynamic management. Its numerator is number of days where the patients have fluid balance ranging from 0 to minus 500 milli per day, and mean arterial pressure more than 65 millimeter mercury with adequate tissue perfusion. And the denominator is all ICU days of discharged COVID patient.
The last indicator in this slide is the percentage of acute kidney injury. The numerator is the number of discharged patients who needed dialysis with no previous history of renal failure, and the denominator is all ICU discharged COVID patients, and it is an outcome indicator. Now, we will discuss the intubation and mechanical ventilation performance measure which were put by the team. The first one is the timely intubation. The numerator is number of intubated patients within 2 hours after positive sign of non-invasive ventilation failure. And the denominator is all intubated COVID patients, and it is a process indicator. The second one in this slide is the uncomplicated intubation. Number of intubations of patients whom their intubation went smoothly. This is the numerator, while the denominator is the all episodes of intubation of COVID patients, and this is an outcome indicator. The third indicator in this slide is the proper driving pressure. The numerator is the number of observations of discharged weaned patients whom their driving pressure is less than 15 centimeter H2O. and the denominator is the all observation of discharged weaned COVID patient, which is an outcome. The fourth indicator in this slide is the patient prone compliance. The numerator is the number of days where patients were in prone position for 16 hours, whom their BaO2 over the FiO2 ratio is less than 150. The denominator is all ICU days of discharged weaned COVID patients, whom their BaO2 over the FiO2 ratio is less than 150, and also it is a process measure. The last indicator in this slide is the proper weaning. The numerator is the number of weaned patients who fulfilled the weaning criteria, and the denominator is all trials for weaning of discharged COVID patient, and it is also a process measure. We will continue the intubation and mechanical ventilation indicators. Here, there is last 5 indicators in our set of indicators. The first one is about successful weaning. Numerator is the number of weaned patients who are stable, and the denominator, all the trials for weaning of discharged COVID patient, and it is an outcome indicator. The second one is the average days of mechanical ventilation. Numerator is the number of all days of mechanical ventilation, and the denominator is the number of all discharges of weaned COVID patient, and it is outcome indicator. ECMO use, this is the third indicator in this slide. Numerator is the number of ECMO patients, and the denominator is all discharges of weaned COVID patients, and it is also an outcome indicator. Average stay in the ICU, numerator is the number of all days of ICU stay, and the denominator is the number of discharge from ICU COVID patient, and it is an outcome indicator. ICU mortality rate of COVID patient, this is our last performance measure in this slide. Numerator is the number of mortality COVID patient in ICU, and the denominator is all discharged from ICU COVID patient. It is an outcome indicator. Then you can notice that the last 2 indicator is related to the stay in the ICU rather than the intubation or mechanical ventilation. And also in this slide, all the type of these indicators is an outcome indicator. Thank you.
Thank you, Dr. Lamia. Now we have arrived at our last station. In the following few slides, we will see how these 30 indicators will be determined. This slide shows the relationship between an indicator numerator and denominator. We always have all COVID-19 patients as the whole population. When we measure a specific indicator, like the timely anticoagulation prophylaxis, we include only discharged patients who received prophylactic anticoagulation in the first day of admission and exclude patients who received therapeutic anticoagulation or still in the hospital. These parameters are called inclusion and exclusion criteria, and both apply to the numerator and denominator. The denominator represents the population which fulfill the criteria and should receive the intervention or the drug, while the numerator represents the population which actually received the intervention or the drug. Here, you will see how to use Excel spreadsheets to calculate your indicator. We used a function to calculate the indicator based on the inclusion and exclusion criteria. This function will retrieve or read from other cells in the Excel file to give an instant result. The contents of the other cells are collected from patient file and documentation forms. Data collector will review the patient file after discharge to fill in these spreadsheets. The first spreadsheet is for patients who spent days of their admissions in the wards or intermediate care units. Each day will be represented in a separate row. The variables here will be found either in the documentation forms or the patient file. The same applies to the second spreadsheet, which is for the intubation, weaning, and ICU stay. This is to be filled in after the patient discharge. The third spreadsheet is for ventilation and hemodynamic management of ICU patients. This spreadsheet is like the first one. Each day will be represented in a separate row. And the final spreadsheet is for medications, dexamethasone, tocilizumab, and coagulation. Again, this is to be filled in after the patient discharge. Finally, data collection will be done through an online form. This is how the form looks like on your mobile or computer. For your information, you will receive an email containing 4 links to these online data collection forms and some documentation forms as an exercise. Those who are willing to get continuing education credits have to complete this exercise along with the quiz to receive the continuing education certificate. This is the end of our training webinar. We hope that it was of value for you. We would appreciate it if you responded to our webinar evaluation survey, which will be sent to you in the same email after your registration. Thank you and have a good day.